Dr. Professor C Manoria at the Second World Congress on Cardiometabolic Medicine at Hotel Leela, Mumbai. And this is the TheRightDoctors.com studio. And I have great pleasure in introducing Dr. Enas A, globally renowned lipid expert. Dr. Enas, coronary artery disease in India occurs at a younger age. One sets in, runs a malignant progression. Myocardial infarction occurs at a younger rate. Revascularization rates are more often, and there's also increased morbidity and mortality. So, any specific reasons why Indians have a malignant coronary artery disease?
Yes, as you know, I came to your major conference in Bhopal some 25 years ago. That was at the beginning of my research. I have been doing this research on malignant coronary artery disease in Indians for over 30 years. Nice. When I said that Indians have many peculiar features, particularly early onset and malignant progression, many of my colleagues in India and the US challenged me, stating heart disease is heart disease. It is no difference between Indians, American, and Europeans. Fast forward 30 years. Now, in 2022, there is no question about the increased rates of heart disease, which incidentally has changed from high rates to high risk of heart disease. Even New York Times had an article, why do South Asians get such high rates of heart disease? I would like to share with you a more startling data which became available in the last 2 or 3 months. Once you are born, you have to die, and heart disease is a nice way to die. But dying before age 50 from heart disease or heart attack, it's absolutely not acceptable. And worldwide, of the 9.5 million deaths from heart disease in 2019, only 8% was in people under the age of 50. So it's very rare. But now, looking at the data which I will be showing in this afternoon, that for Indians account for 30% of all the death under the age of 50. Now, and India account for 18% of the world's population and 30% of the death. United States, 4% of the world's population and only 2% of the death. So this doesn't happen in China, US or UK. So Indians indeed not only get heart disease, they die young.
So the next question arises, are there any specific reasons for this, genetic or otherwise?
That's a very good question. Thank you for asking. Genetics loads the gun and environment pulls the trigger. Yes. We had a genetic problem mediated by what is called lipoprotein little a. I call it deadly cholesterol. You all have heard about good cholesterol, bad cholesterol, ugly cholesterol. I have termed lipoprotein little a as the deadly cholesterol. The tragedy of the fact is that high levels of LPA little a. In 1996, I reported 1 in 4 Indians have high LPA little a, and if you take 20 at the cut point, 44% of the Indians had higher lipoprotein little a. Now the National Heart Lung Blood Institute special paper reported that worldwide 20% of the population have a high LPA little a, but for Indians it is 25%. Yes, so this is a major factor which is 3 to 4 times more common than diabetes. Everybody understands diabetes, but 50% of diabetes is not diagnosed. Lipoprotein little a affects 25 to 44% of the population, 99% of that remains undiagnosed.
So the next question arises, when LPA level should be estimated in the Indian context? And does it require repetition or only single reading is enough?
Lipoprotein little a, currently only one reading is sufficient unless and until the LPA little a lowering medications are approved and used. So for the time being, only one. The Canadian guidelines recommends measuring lipoprotein little a along with the first time lipid profile is measured. So my recommendation would be the same. The very first time you measure the lipid panel, you should also include lipoprotein little a. But there are many caveats in measuring the LPA little a. LPA little a, we all know about the small dense LDL and large LDL. I am not a believer in that one, but that's different point. But lipoprotein little a has 40 different isoforms or 40 different particles. And the usual measurement underestimate the levels in those with the small isoforms and overestimate the risk in people with large isoforms. But there are tests now available in in India, and companies are located in Mumbai, where you can buy kits which can run on usual chemistry machines and give accurate results. And accurate results should be measured by an assay not affected by isoform size and preferably measured in nanomoles per liter.
The next issue is the larger particle more atherogenic or the smaller particle more atherogenic? What is the reason?
Large particles are not atherogenic, and small particles are highly atherogenic. Now there is a relevant question is that most of the studies done to date underestimate the burden of risk of lipoprotein little a because the small particles deteriorate on storage by about 50 to 60%. And most of the studies done to date are specimens stored for 20 years. So when we are measuring in patients, it's always measured in the fresh plasma. You are going to get much higher levels. And in fact, Dr. Kamal Sethi, you know him from Delhi, it's one of the speakers. He told me when he is ordering the test, he is finding results 50 milligrams, 100 milligram, 200 milligram. He was even skeptical whether the results are accurate. So my point is that in the fresh specimen, when you are measuring on patients, the levels are going to be much higher than what we usually hear. Another point is that the UK Biobank study has just published results based on a study on 500,000 people, including 16,000 South Asians. LPA levels, this was in a frozen preserved specimen, LPA level in South Asians were 60% higher than in whites. So not only we have a high levels, it's significantly higher than in whites.
So the next question, at what level LPA becomes atherogenic? What is the cutoff point?
So that is another very important question, and my reading and also experience and studies done in India on LPA little a shows that LPA little a 20 becomes atherogenic. So it should be an acceptable cut point for Indians. But conservative debate is now still not decided which should be the cut point. 30 milligram was the cut point by the US guidelines. Then the European guidelines changed it to 50 milligram. So in the US, the cut point is 30 to 50 milligram if the range is used. So you can use any one, but for Indians, in my experience, it becomes atherogenic by at about 20.
It is understandable it has an atherogenic potential. Why it has a thrombogenic potential also?
That's a very important question. Okay, the LPA is determined by LPA gene, and LPA gene evolved from the plasminogen gene, and so it has some antifibrinogen because of the structural homology with the plasminogen. It produces thrombosis as well as antifibrinolytic. Besides, it is the sole carrier. Almost 90% of the oxidized phospholipids in the blood is carried by lipoprotein. It is also the highly dangerous in producing malignant heart disease because it starts plugging the arteries by the time you celebrate the 6th birthday.
So do we have any effective treatment at the present state of time? Somebody has a raised LPA.
Yes, this is another very important question. Currently, remember that LDL and cholesterol was known as contributing to heart disease, but nobody believed lowering would benefit until 4S study was done. 4,444 people in 4 Scandinavian countries, and they gave 20 to 40 milligram of simvastatin and waited and waited and waited until 444 of them died. You cannot do a study in India or in US, studies like that. And it showed there was a 30% reduction in death. That's how doctors became convinced that lowering the LDL benefit. But what is not known was that the reduction in mortality was only 15% in who had high LPA, and reduction in mortality was 50% in people who had low LPA. So even in the 4S study, it was a determinant. But for the currently, the recommendation is in people with LPA, there is a risk from LPA and the risk from LDL. So you knock down the LDL to 70, 60, 50, 40, and like 30 as much as you are comfortable with. So knock down the LDL and wait until 2025. The pelacarsen is being tested in an outcome trial called Horizon trial. But don't put too much confidence on that research because these are going to be extremely expensive medications. For practical purpose, my recommendation is that you should start lifestyle modification starting at age 2. Do not wait for the first heart attack or stent. Lifestyle modification starting at age 2, continuing until age 5, and it's very high LDL. And lipidologists like me, we start the statin therapy even at age 5. Most statins are allowed and recommended starting at age 10. So from 2 to 8 years, lifestyle modification, and you can reduce LDL starting at age 10.
Thank you very much, Dr. Enas, for the great deliberation. I'm sure all will enjoy the flashes of your expertise. Thank you very much.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.